Hello, and welcome to another episode of Gab and Grow. This is number 14.
Yes, I believe if
Oh
we post
my
them in
God.
order.
Oh my gosh. My name's Amanda Pellegrino, and I'm a pediatric occupational therapist. We are also joined by the
Allegra,
one, the only. Oh, I'm sorry. I was going to do a more grand intro for you.
Allegra Berezno. I'm a speech language
Woo!
pathologist. And
Yay!
what's new with you, Amanda?
So what's hilarious about these little intro chats is sometimes we record back to back. So it's like we've literally just had a conversation and we also talk every day. So like maybe
Well,
we need to
what'd you do this weekend? We haven't talked
okay,
about that.
what did I do this weekend? I
I actually
went
know what you
to
did because we chatted, but what'd you do?
Do we need
How
to
was
start
it?
being those people that it's like save it for the pod? I went to Rhode Island for my dad's birthday, and my sister's going to school in Rhode Island. So I stayed with her for a night because she's a senior in college, and I went to college and I felt
Nice.
really old.
How was that?
It was really fun. Her friends are so sweet. It was fun to hang out with my dad and my parents, and my brother was there.
Did your
Um,
brother go out too with you guys, or did
yeah,
he?
he did.
Nice.
He
That's
did. I know, and he goes to school in upstate New York, so we don't often all get together, so that was really nice. And then I came back and I went to the Boston Public Library for the first time ever. It
checking
was
things off your list.
I have a bucket list. I'm open to any
I love
suggestions.
the public library. Have you gone to the Isabella Stewart Gardner Museum?
I have. That's
Okay.
been off the list.
Maybe we should try to do something this weekend.
Okay, what do you think should go on my bucket list?
Do you have anything that's left unchecked yet?
It's not like great stuff,
What about
quite
the MFA? Have
honestly.
you been to the MFA? I haven't
I
been there in
haven't been to the
years.
MFA.
Casey and I were
Okay,
talking
I
about
think
how we
the
wanted to
MFA.
go. Oh, we should.
You're gonna hate this idea because I don't think you're going to want to do this, but there is apparently the MFA is doing a line dancing night.
I would love that if I wasn't 38 weeks pregnant.
That's what I was gonna say. That's what I was gonna say. I don't think
Like,
you're gonna want to do this,
my cowboy boots will
but
not fit over my calves right now.
we should just go to the MFA. Okay, that's on the list.
When is
I
this?
want to go out to dinner.
When are they doing the line dancing?
I don't know. My friend told me about it, but I said that would be really fun.
That's funny.
Casey would go.
Yeah. Yeah.
Casey would enjoy that.
Okay, we'll look into that.
I
But
want to go to
either
a
way,
Celtics
we
game.
should go.
Okay,
Okay.
great. Okay, great. Anyway,
We would love to go to a Celtics game too. So
okay.
I think I've been to one Celtics game ever.
Really? Oh my gosh,
Yeah,
they're so much fun. So my husband refuses to go to a Red Sox game because he's a diehard Yankees fan.
Red Sox
And
games
so
are the
now
best. You can get tickets for
it's opening
cheap.
weekend in
Is
2
it?
weeks. Yes.
Okay, well, maybe.
But Mike won't go. He won't go. He
Oh,
refuses.
because he'll be back.
He'll be back, but he refuses to go to a Red Sox game. Maybe Casey can convince him.
Yeah. Who are they playing? Too bad they're not playing Yankees.
I think I know about that.
That would be
We
nice
got
if they were
enough on our
playing.
plate.
If they were playing the Yankees, then that would be a good excuse.
Yes.
Anyways, what are we gabbing about?
What are you gabbing about? Gab to me, Allegra. I just gabbed to you.
I'm going to gab. So last time we gabbed about myofunctional disorders, specifically tailored it towards like airway and breathing and sleep as like a system. So I was thinking, okay, I feel like every episode I have a plan and then it derails a little bit. But
Sorry.
I was thinking of like tailoring it more towards another system of how myofunctional disorders can impact feeding and swallowing. So I know I've chatted a little bit about this in terms of like infant feeding and swallowing. So I'll kind of briefly touch on that today, but talking more about like school age or even adult feeding and swallowing. And then you had a couple of people reach out about lip taping. So tell me about that.
So before we get into myofunctional with feeding, I was wondering, I had a couple friends kind of mention to me that they do mouth taping or they're interested in doing mouth taping or they've seen it, they're not sure. So like to what degree, I guess, some of these challenges we mentioned would constitute getting more information on this and obviously seeing your ENT and making sure you check all your boxes. But like I
Yeah.
guess like when is it? Yeah, you know what I'm saying.
When should they even like consider it, I guess, is the
Yes.
question.
Yes.
I would say, like, first, do you know if you're breathing through your mouth or through your nose when you're sleeping?
Hmm.
Because if you're breathing through your nose, there's no need to breathe like mouth tape because your mouth is closed. So if you're, which is like hard if you just sleep by yourself. But here's some cues of like if you wake up with a dry mouth,
Hmm.
that's a cue that you've been mouth breathing. If there's drool consistently like on the pillow or something like that, that's another cue that your mouth was open when you were sleeping. Some things that I like to ask too, especially like adult clients, is where is your tongue resting like all the time? Like right now, your mouth is closed. Where is your tongue? It's kind of a hard
Well,
question.
as you said that, I started paying attention to it. I think
Yeah.
it's on the top of my mouth.
So that's where we want it to be. We want it to be again like suctioned, rest like full tongue resting on the roof of our mouth. And so even just like paying attention to that as you fall asleep. And I think we talked about this last time, but like repeating a little mantra in your head of like tongue up, lips closed, breathe through my nose. Thinking about it and being more aware of it as you're falling asleep can help it stay that position throughout the night. If you also might notice if you're sick that then you start waking up with a really dry mouth or more of those mouth breathing cues because you haven't been able to sleep with breathing through your nose. So I would say like to determine if you want to try mouth taping, it's like, well, is there a need for it?
Mm-hmm.
If you have no signs, if your partner is like your mouth is closed when you're sleeping or I don't hear any snoring. There's no
Sleep.
teeth grinding, anything like that, you don't
I
really
grind
have
sometimes.
to. And grinding can be a symptom of like airway. It's
Huh.
almost like the opposite that you would think of, but you're clenching and you're grinding because you're actually trying to get more air in. And you're like, it's like
Gosh.
tense and trying to get more air in. So I would say start there. Like start by
Okay.
just determining if you're breathing through your mouth or through your nose when you're sleeping. And also like when you wake up, try to get into a habit. And you can do this like if you wake up in the middle of the night too. But like before you even open your eyes, just be like, what's my mouth doing? Where's my tongue? And try to
Good
cue
idea.
yourself into that first. And then if you're like, oh yeah, mouth breathing. If during the day you're consistently nasal breathing and you try some mouth tape when you're like winding down, like watching TV or something, and you're able to breathe through your nose, again, I always recommend like seeing an ENT, making sure that anatomically there's not a reason why you're not nasal breathing. then
Hmm.
then I would say give it a try. And I like to actually say like try for 2 weeks straight before you decide that it is or isn't a good fit for yourself, because especially in those early nights, like if you're so consistently mouth breathing when you're sleeping, your body will probably just take off the tape when you're in the middle of sleep. So that's another cue too of being like, oh, maybe like
That's
my
funny.
body needs to breathe through my mouth for some reason.
Mhm.
So it's like all good data to have on yourself. But I would say like give it 2 weeks to see if you notice a difference in your energy levels and if you're able to wake up easier, if you're not as tired throughout the day, because those are all signs that you weren't nasal breathing prior to the mouth tape, and
Hmm.
now that you're forcing yourself to nasal breathe, you're getting better, more quality sleep.
Very cool. That's really interesting. Anyway, I just
Okay.
wanted to kind of toss that out there. We don't have to spend too much time because I know we just did a whole episode on that. Go back and listen if you haven't listened. Allegra dropped some knowledge on me as per usual. But you wanted to talk about
Feeding and
myo
swallowing.
feeding and swallowing. You went through the most crazy in-depth sequence of like the anatomy of feeding and swallowing, which was the coolest thing ever. I guess like
Yeah, that was a while ago, right?
it was a while ago. Yeah. But it's so complicated. So I'm really curious to hear like how can we make this even more complicated?
It's like this is going to make it more complicated, but I'm going to relate feeding and swallowing issues in relation to a tongue tie, and
Mm,
try to keep it like just within that scope. So we talked a little bit about on that first episode, let me pull up which one it is, but we talked a little bit about feeding and swallowing in terms of infants and when they have a tongue tie and how
Mm-hmm.
a tongue tie can affect infant feeding and swallowing and
Mm-hmm.
how it can be pretty impacting for not only the infant, but for the parent that's trying to feed them. So
Mm-hmm.
that was in episode 9, and that was the OMDs across the lifespan, infant ties and feeding. So if you are more interested in that age population, go back to that episode and listen, because I'm going to just touch really briefly on that right now. But the main issue with a tongue tie and infant feeding is latch difficulties. They are unable to efficiently latch to a nipple, whether it be breast or bottle. It could be either one. A lot of times we actually do see a bigger issue with transferring skills between breast and bottle. So they might be
Mm.
successful in one, but then unable to transfer that skill in the other. And a lot of the issues are like signs or symptoms of this can be clicking sounds from the baby as they're stuck. Pain for the mom is a big one that I think a lot of moms ignore, and they say, well, it's supposed to be painful. And practitioners might ignore it, like, oh, well, you're just getting used to it. It shouldn't be painful. It's especially after your milk comes in. So in those first few days when you're transitioning from colostrum to milk production, it might be a little bit more painful, but yeah, if you're like this, if you're like wincing in pain during a feeding or prior to a feeding, then that can be an indication, especially when it's like lasting multiple days. That's what it can be an indication of something anatomically happening. And I want you to also remember that like it's not the mother's fault. It's not the baby's fault
Yeah,
either. It's just
right.
the anatomy that between breast nipple and the anatomy of the baby. Something just might not be completely working together. So problems that arise from latching issues can be failure to thrive. I hate that name, that diagnosis.
I know. I know.
Because that's like really scary for a parent to get. Prolonged and frequent feedings is another sign. Really long feedings. We say feedings should last ideally 30 minutes. Like it can be up to 45, but for breastfeeding, ideally 30 because like especially infants, like they're eating a lot frequently. So
Mm-hmm.
it's like
Mm-hmm.
once you're feeding more than that 30 minutes, then it's encroaching on the next feed. And it's like, are they going to be hungry for that next feed? So we try to do not timed feedings, but you just want to make sure that they're not eating for super long periods.
They're working harder at this than they need to be.
And if they're working really hard, then they're starting to burn calories and they're not getting as many calories in. So it's almost counterintuitive.
Okay.
Poor milk transfer for the mother.
What does
And
that mean?
so that is just like you're not getting, like the baby is not getting a lot of milk from the breast.
Oh,
So I'm going to talk a little bit more about reflux.
I was gonna say that is a tough thing for poor, like when babies have reflux, I feel like it affects so many different
Yeah.
things, and we've seen it almost impact postural patterns of like, I am going to go into extension to avoid
Yes.
reflux or try to get away from whatever's coming. So it gets confused with like, oh, they have tone, but really it's a learned pattern because of GI symptoms or like reflux or whatever.
So
So that's something I've seen on my end.
that's interesting that you point that out. So it's like you're arching your back really big and your
Hmm.
arms are stretched backwards and big.
Hmm.
Um, I see that happening more either mid feed or after feed because they're uncomfortable and they're trying to get like because of the reflux. Do you see that? Is that when you're seeing it too? Or are you thinking more of like now it becomes a behavioral response in regards to feeding?
It could be both, or it could just be as they're moving in general, they get
Mm.
reflux. And so then that,
Yeah.
reflux is obviously on a spectrum of degree of like how often you get it. So I think that's something.
It's like so many kids
Yeah.
have, so many babies have it. They're so tiny and it's all just compressed.
Yeah.
They're like squishy little bellies.
Little bellies. I love a little round baby belly. So
So,
cute.
so with a tongue tie, we can see increase of reflux and aerophagia. So aerophagia is excessive swallowing of air, and those both can cause abdominal distension, which we were just talking about squishy bellies, but
Hmm.
like a big belly filled with
Big Valley.
air. Think of how uncomfortable that is. Frequent like burping and flatulence.
Do you ever do any abdominal massage, like the I love you massage? Have you heard of that?
I do. I'm not so familiar with the I love you one, but I have done abdominal massage and I've taught parents a little bit of there's some really good resources online to find abdominal massage for infants in regards to feeding.
Okay. Should we post
Um,
those? Post some
yeah,
resources?
I'll have to find some. I usually just like look them up in the moment. Yeah, and you can also refer out to a body worker. And I think we've talked a little bit about this in the past. So either a PT or a chiropractor that might specialize in infant massage or OTs. I've worked with OTs in the past in early intervention that have done specific training for infant massage. I don't have specific training. I kind of read the baby's cues and go off of that when it comes to abdominal massage and
Mm-hmm.
see if it
Mm-hmm.
helps. Have you had
Awesome.
experience with?
No, just through taking a course, they mentioned that I love you. And I'm not confident enough in it to explain it or teach a parent, but I have seen other people be confident in it. And it's essentially, I think, following the GI tract of like pushing air
Yeah.
or I
You
guess
want to
whatever.
you want to do it when they're laying down or laying on their back. And I think there are specific timing of like when the best time to do it in relation to a feed is. So working with somebody that knows a little bit more than me. But that's something I would refer out to if infant has a lot of reflux. So the big thing with infants and reflux is that it can present as just irritability and pain in their baby, so they can't tell you that they're uncomfortable or in pain. So you have to know their cues.
Hmm.
Crying uncontrollably. That's why we do see a lot of like colic like symptoms.
Hmm.
And we're like, why are they crying? What's what is the reason for the crying? A baby is crying to communicate something, even if it doesn't feel like that. And you're like, well, I don't know why they're crying. It might be because they're uncomfortable. And there is some good research coming out too of tongue ties and colic and their overlap because of that, again, aerophagia. It doesn't present necessarily as a traditional reflux. Like they might not be spitting up a ton or having those cross the room spit ups or vomiting after feeds. Instead, it's because they swallowed a lot of air because their tongue is restricted to their floor of their mouth and they can't get a good seal on their palate when they go to swallow when they're eating. So that's where the aerophagia and the reflux kind of differ. Um,
Hmm.
and again, some signs dislike lying down. We have the arching the back, the
Hmm.
sorry, I lost again. I'm doing like a course this weekend where I prepped for all this. So I'm just kind of reading up some of the symptoms.
Perfect.
Difficulty sleeping, laying down, arching their backs during or after the feeds, problem swallowing, uh, not demonstrating like a good suck pattern, and like gagging, coughing, hiccuping. We talked about hiccuping in our last episode in relation to vestibular system, but this is with
Hmm.
feeding.
Hmm.
And some infants will learn to refuse feeds and or constantly be feeding because like the act of swallowing actually helps keep things down. So it can actually go either way. So like refusing feeds because they make an association of like feeding makes me not feel good, so I'm not going to do it, which is
Yeah.
not great. And then the
Right.
other opposite is like I'm going to eat all the time because I need to constantly be swallowing to keep this down. And so that is times too where I'll say like try using a pacifier because then they're able to suck and swallow that air down. That's kind of a band-aid fix though for it. Like I wouldn't that's just something to do in the meantime. In relation to older kids, I want to talk about
Hmm.
reflux. We do see a lot of like school age kids too that struggle with reflux. Typically, infants grow out of reflux once their bodies get a little bit bigger. But when we're talking about tongue ties, they're not growing out of their tongue tie unless it's been revised or tongue tie clipping, surgery, whatever you want to call it. But we see older kids that get reflux because the same issue, their tongue is restricted to the floor of their mouth and they're swallowing either too much air because their tongue is
Hmm.
not pushing up on the roof of their mouth to swallow, or their chewing is insufficient or inefficient. They're not chewing their food fully. So they're swallowing their food not fully chewed, and then that can come back up in reflux later. So I don't know if that was something that you were
I
aware
mean,
of.
no, I didn't know most of this, but I think what I was thinking about as you were talking is I was curious, when did the research start to come out more about tongue ties? Like, is this an old phenomenon where people have known about this forever, or is there like a generation that maybe missed this? And
It's more
that might be a
um
hard question.
I mean it's not anything new.
Okay.
The research and the thing that's frustrating in this area of the field too is that there's just not a ton of um quality research in one area. So you have to like really be looking at dentists, like journals of dentistry. They have some really good
Mm,
research. Journals of otolaryngology or ear, nose, and throat. They have those two, I would say, have way better research than speech pathology journals.
makes
Um,
sense.
and
Yeah.
so that's kind of where, like, I just did a huge research poll for this presentation. That's where I was the most successful in finding overlaps. They don't have great research in terms of speech and articulation. And I'll talk about how a tongue tie can affect speech and articulation later in another episode, but that is what we see the research coming out as. And you don't learn this in grad school. I don't Most dental schools you also don't learn about this. So it's a lot of continuing education that the providers need to have. And that's also what makes the field difficult too, because you can see one provider that's very well versed in the area, and then you can see another one that has the same degree and credentials that are like, I don't know anything about
Mhm.
this, or I don't believe this. And then that can create a lot of confusion for the parents.
Yeah.
So and it's hard to find because there's no like universal board, I guess, or certification for all of these different professions when it comes to
Hmm.
myofunctional disorders. It's hard to find people that have training in it. So I always say like looking for a airway centric dentist or even a holistic dentist, because those can be some good search cues. And then looking at myofunctional therapy when you're thinking about like feeding or speech therapy. Trainings in TOTs, so tethered oral tissues, is a good one for when you're looking at lactation consultants. So yeah,
Yeah.
those are just some search cues to when you're Googling providers.
Think what I'm thinking about is like I feel like there's definitely people that this gets missed for sure, because it sounds like it can be brushed off as something else, or maybe your professional doesn't have the training or you don't have the resources, unfortunately, to access the knowledge or the whatever. You named a bunch of professionals that I don't remember, but go back and look into. I wonder, like, what does this look like in adulthood if you
I'll go
miss
into that.
this?
Well, yeah, that's the other piece of it is like somebody might mention it when they're an infant and they're having struggles with eating. And then usually it does kind like it seems like it gets better, or you put up with it until the child is like 6 months old. And then they stop having all the colic like symptoms because they're getting bigger and their bodies can handle the increase of air that they're swallowing, and they're just not as uncomfortable. They're sitting upright more. Their core is developing. All of those things work in their favor, and then they stop crying uncontrollably. Or you've figured out, okay, they do better with the bottle. We're just going to go off the bottle. And they're
Mm-hmm.
starting solids. So, like, why do I need to worry about transitioning between breast and bottle? Like, now we have solids
Mm-hmm.
in the mix. Like, they're eating enough. We're fine.
Mm-hmm.
So, like, that you might have had a professional kind of mention it in passing when they're a baby, and then it seems to get better at that age
Mm-hmm.
ish. And then you just kind of put it off and you're like, okay, we don't need to do anything. We're good. And then in school age, that's kind of when you might see more of the sleep issues that we
Mm-hmm.
talked about. And I'll talk more about speech and articulation in another episode, but you might see some of that overlapping. Picky eating is something I'm going to talk about next in relation to tongue tie. So you might have a child that is a pretty picky eater, or reflux because they're not chewing their food, or is a picky eater because they can't chew their food. which is like another piece of the puzzle.
Mhm.
And then in adulthood, same thing, open mouth breathing, picky eating. There are adults that are still picky eaters, and you like don't really notice because they've figured out.
You just adapt to what is going
Yeah.
to work for you.
Yeah, they have struggles sleeping and they might need to mouth tape. So it presents in different ways, and it's across the whole system. Adults that need second, third round of braces. Those are because where that tongue was resting has now affected the bite.
Dang. I feel
So
like I'm thinking about like this is probably so unrelated, but like maybe a generation of like my grandpa's age and they all smoked cigarettes. Were they all smoking because they had tongue ties and they needed to keep their reflux?
and oral habits, that's actually a big one too that you see in myofunctional disorders, just like oral habits.
What does that mean, oral?
Biting on your tongue or your cheek, biting your nails,
Bite my cheek?
smoking.
I don't think I have a tongue tie, but I do bite my cheek.
A lot of times it's like it's hard. It's not just like one size fits all, right? It's hard to determine because it's like, well, we also that might just be more of like an anxiety piece too, and we do it during certain situations. So
Yeah. And I think it's like collect as much data points. And it's like if all
right,
of these things fall along this column, it's like, okay, maybe we have more information if it's like here and there and scattered, then
right,
that leads to a different
and
understanding.
back to like a full functional evaluation to help kind of figure it out. So we also have like a tongue thrust swallow. So that's what's causing swallowing air, too much air when that tongue is pushing forward versus pushing up. So then we also can see dental occlusion, malocclusions with our bite when that tongue is pushing forward
And that's
instead
like,
of
is that
just
the kid
sailing up.
too, that if they're taking a glass of water, they're like,
Their tongue is underneath the cup. Yeah.
yes.
And a lot of times we see that as like that their tongue is stabilizing that cup, not the lips. So that's actually a compensation piece. So they're not using their lips functionally. And we need to teach them
Mm.
how to do that so that then like if your tongue is under the cup, you're not swallowing correctly because only the back of your tongue can move when you're swallowing. So you're swallowing more air. Increased
Mm.
choking or coughing due to an incorrect tongue position during the swallow, and also due to not chewing your food fully. So if your tongue is pretty restricted to the floor of your mouth, it's a lot harder to get your tongue back to the molars and bilaterally, like laterally move that tongue from side to side on those back molars to chew up, especially those chewy foods. So like steak, pork, and like raw vegetables, anything that's just tougher to chew. Speaking of which, picky eaters. So a lot of the times our picky eaters are kids that are not eating a lot of meats and are not eating a lot of vegetables because those are the harder to chew foods. And they might love, but parents will come in and they say they'll eat chicken nuggets all day. They'll eat not boiled, like steamed carrots and broccoli. Those are softer foods because they're not having to chew them. Like I call chicken
Mhm.
nuggets like pre-chewed meat because you don't have to do anything. But if they like won't eat a grilled chicken or
Never
steak,
thought of it that way.
yeah, it's kind of gross, right?
I guess you're right.
But thinking of like it can turn behavioral, but the biggest thing is can they learn that, oh, I don't feel safe eating these hard to chew foods, so I'm not going to eat it. But they don't know that. They cognitively like that's a lot of
Yeah,
self-awareness. So they
right.
say, I don't like it. And that's why they don't eat it.
Yeah.
So that is my kind of rough feeding and swallowing and signs that it might be a myofunctional tongue tie issue on top of like just this again one symptom, so like one subsystem that we're talking about. So if you are like, okay, well this sounds like my kid, also the last episode with the sleeping and the breathing sounds like my kid, then and like
Hmm.
these issues happened in infancy, those are kind of red flags to being like, maybe I should explore this area a little bit more.
Hmm.
So
Well,
that's all I got.
wow. I'm like, is my husband snacking problem because he has a tongue tie? That's my next question. He
It's
loves chips, but I don't think they're related.
and that also might be a sensor. Like that's the thing with feeding. It's like that could also be a sensory thing because he wants that feedback of the crunch.
Yeah, I've been roasting him a lot on this podcast. I think I need to reel it in.
He doesn't listen, so it doesn't
He
matter.
doesn't listen, so it doesn't matter.
Okay, I have to give you a household item. Should I make
Okay,
it? Can I make it tailored towards anything?
you could try. I don't know if I'll be able
I don't know
to
if
do it, but
feeding
I can
feeding
try.
one is kind of tricky. Okay, well, how about like an open cup? How would you
Like
work on taking sips? Yeah,
like a
yeah.
glass cup. I'm taking sips.
Like, is that
Okay,
like
we'll
too
try
much?
it. Well, you know what? I'll try, and then you need to approve it because I am not a feeding therapist.
So
If
they
they're
use
working on,
something that we just talked about.
let's say they're working on taking sips, I'm gonna say let's use something really thick, like slightly melted ice cream. So it's like coming down really slowly,
Mm-hmm.
and their job is just to like try to get it in their mouth without
Think about
using
tongue
their tongue.
positioning.
Yeah, think about tongue positioning. I'm gonna tell them think about tongue positioning.
So one good thing to say is like if you see your kid greeting the cup or the spoon even with their tongue, keep your tongue inside your mouth. Like
Yeah,
only your lips need to hold that open cup. And then tongue up to swallow.
what I'd say, goodbye, tongue. No tongue.
Keep it in the cave. That's what I say.
Ooh, cute.
Your teeth are the bars. Keep your tongue in it.
The tongue in the cage. Yeah, no, that was
Um,
really hard for me. But I think ice cream would be a really motivating activity.
yeah, or like a thick smoothie, to move slowly. And you can even work on straw drinking with those
Mm.
thicker consistencies. It's actually working the tongue muscles really well of like having to actively suck through the straw.
See, that's what I
The
was about to
smaller,
say.
I know, I would told you open
I'm just
cup.
kidding. I really wasn't gonna say that.
A smaller straw with a thicker consistency makes your tongue work a lot harder. So, like a narrower straw with a smoothie, and you're working a lot on those tongue muscles to have to like retract and suck through the straw. And then I think it also, from a sensory input, it's giving them a lot more sensory feedback.
That's where I was gonna go with that next. I was gonna say, and it's
Sometimes,
heavy work. It
yeah.
is heavy
And
work.
I see my sister for myotherapy. She's 24 right now and she has Down syndrome. And one of her homework exercises is to drink a cup of yogurt through a straw. And
Oh,
it's
that's
hard.
hard.
And she started with like we set a timer for 2 minutes and she just does as much as she can. And now she's able to do the entire cup. Like, it's great. And we're working on just that
Yes, girlfriend.
tongue tongue retraction muscle because just low tone comes with Down syndrome. So
She does the butt
the
pull.
button
Great.
pulls, we've kind of moved past that one. That one got really strong. But that's all we
Yeah,
have
girl.
time for today in terms of feeding and swallowing and myofunctional disorders. So let us know if you have any other questions we can touch base on. But I'm going to switch systems next episode and make sure you
Sweet.
like,
Like, subscribe, comment
rate,
about how funny and cool and awesome we are.
and goodbye. Thanks for
And goodbye.
gabbing.
Thanks for gabbing. Bye.